All right. Well, good morning, everyone, and welcome to the Prevention Perk. I'm your host and moderator, Steve Miller. This has been one of those segments that I've been looking forward to. Each one of them has brought something unique to the perspective of prevention work that we do in our communities. But I really feel like today's topic is something that we'll all probably learn something new from. And not that I've not learned from the past experiences, but epidemiology is a word that's taking me about a decade to even learn how to say. And that's just because Ricky coaches me when we do the substance abuse prevention skills training on how to use that word. So I'm hoping to, and I can define it now. I'm hoping that maybe we can learn how to implement it after today's discussion. If you didn't get a email from me recently, I'd be happy to remind you that we're soliciting your feedback, comments, concerns, aspirations for future prevention programs. You can deliver those to my mailbox. If you have a topic of conversation that you would like for us to delve into, I have heard from a smattering of our past participants, and we will be putting together another lineup of about probably 6 or 8 topics going forward that we'll be discussing. I do know that we've been doing this on a bi-monthly basis. And going forward, beginning in July, we're going to just shift to hosting it once a month on the 3rd Thursday, same time slot. But we kind of started this amongst the pandemic, and I know that people are kind of shifting back to in-person meetings and things along those lines. But I do feel like that we have built a little bit of a following, as is representative here today. We have right now 17 people on the Zoom. And this is all designed to just be a casual conversation about a specific topic, similar to how if you met someone at a coffee shop and you struck up a conversation with them and you found it to be quite interesting and you learned something new that you could share with others. And I know that I also like the aspect of this technology in that it has a way of bringing people together from other communities. And we've also had other participants from across the state join us. So that's always a real treat when we're able to have, through the luxury of technology, to have Nina Carter on with us because she's out in Douglas County. And it's a lot easier to just push a button and be involved in the conversation through Zoom. And there will still be value in both in-person and this type of format. So I'm hoping that we'll still have the audience going forward, and that if you do have a subject that you'd like for us to delve into, or if you say, hey, I am an expert on something, close your ears on this part, Scott. I'm an expert on something. I would like to be a guest on the Prevention Perk. We'd love to visit with you about that and get you plugged in, because the more the merrier. And I've really learned a lot as we've gone through this. I think this is our 17th segment of Prevention Perk. So we've covered the gamut from drug prevention to bystander awareness, mental health first aid, and today epidemiology. So there is a lot going on, and hopefully a lot more. I think what we're going to line up for our first one in July is going to just be a conversation about some of the challenges that coalitions are facing, whether not just challenges, but some of the things that are also working real well, whether you're in the Springfield area or you're in a more rural coalition setting. And we'll kind of talk a little bit about those in July. So look forward to an invitation in an email box near you soon, and we'll press on. So again, I'm glad to see everyone is here today, and I'm really excited that we have the epidemiologist with us for the Greene County version of the Partnership for Success. I am the project director for the regional PFS, and Jill Latimer, who's also on this call, is the project director for the Greene County PFS, and then Clement is the epidemiologist. And he is just a very unique individual. I have learned so much from him, not only about epidemiology, but a lot about our cultural differences. And we have great conversation about graphics design work and just a number of things. And so it's been a real treat to get to know this gentleman. And when I was thinking about adding an additional segment to this, I thought, you know, when Ricky and I do the SAPS training, we always get to epidemiology, and you get a smattering of hands that go up when people talk about, you know, evaluation and numbers and research and that kind of stuff. But most of the time, we kind of see people, you know, take an early exit to go to the bathroom or want to hide under the desk, or, you know, it can be for some people an intimidating science, if you will, and to really wrap our brains around, you know, really the importance of using epidemiology in our work. And so, you know, I put in the title of this when I emailed it out that it's really, I said, you know, epidemiology is find the problem and then measure your success. And that's really why we talk about, when we do the SAPS training, all of those components of this strategic prevention framework are intertwined with one another. And this evaluation aspect needs to be a part of it from the get-go. And in my experience with working with coalitions, you know, that's not always the case. Evaluation shows up when one of us sends the reminder out to the coalition leader, hey, your mini grant final report is due. And they're like, oh, we didn't do any evaluation, right? And I don't know that that's always intentional. I think it's just, it's one of those things that just kind of escapes some of us. So I'm hoping that through this conversation today that we're able to add a new light to it. And I want to go ahead and just jump right into this. I have a few more people, looks like, that are joining us now. But thanks for joining us today, Clement. I guess we'll start out with the most obvious part, and we'll see if you can give us all a working definition of just what is epidemiology.
All right. As Steve had said, my name is Clement Champong, and I am the Greene County Partnership for Success epidemiologist. He said a lot of stuff, most of which are true, most of which I would say
What's not true what I said?
Should be conversations we just have across the. Well, you made me look like a superhero.
Ta-da!
But I'm just an epidemiologist. So I'm going to go ahead and share my screen here in a second, and then we can get started. Oh, I need access, Steve.
Yeah, let me go ahead and make you. No, I don't want to do that. I want Clement to be my co-host. There you go.
All righty.
And do keep in mind, everyone, as Clement's talking and we get going here, that you're just as much a part of this conversation as I am. So get your questions ready. All right, Clement.
All right. So I'm excited to have you all on the call this morning. We're going to look at basic introduction to epidemiology. I tried my best to make sure that I wasn't using a lot of technical and complicated stuff for this presentation, because I wanted to make it to the point where everybody on the call could relate to it. And hopefully by the end of the 30, 45 minutes that we spent on this call, you would feel like you have learned something new from an epidemiology standpoint that you can take into your workplaces or even into your daily lives and how you look at problems in general. And this is always the hard part of my job, having to explain to people what I do. Say you are an epidemiologist, that sounds fancy. What do you do? Well, I always try to make it very simple as I can. And I tell people, when you have a headache, or when you're ill, you go to the hospital and you see a doctor. Well, my job is kind of like a doctor's, only that I have to have a group or population to work with. So good luck if you just having, say, cancer and you want me to help. I can't help with that. But if I have a whole town with cancer, then I can help with that. And that's what this cartoon is trying to communicate. So he said, I'm sorry, Dr. Etheridge is an epidemiologist, not a general practitioner. But maybe if you get a group together, he could see you. So this presentation is going to follow this outline. We're going to start off by looking at public health in general, just because epidemiology is one of the core concepts of public health. We're going to look at key concepts and terms, and we're going to look at calculating rates. And I'm going to explain why that is important, because it's not enough to just look at the numbers. In epidemiology, we like to go a step further and look at the rates. And then we're going to look at the approach and the methodology used in epidemiology, data sources and design, investigating disease outbreaks. Okay. So let's talk about public health in a broader context. Public health problems are diverse, and they could go anywhere from infectious diseases, chronic diseases, emergencies, injuries, environmental health problems, and what have you. But they all, to address them through an epidemiological lens, we tend to go through, if you would like, this logic model. So we start with what the problem is, and typically how we do that is by collecting surveillance data. And once we identify the problem, we want to find out what is the cause. What are the risk factors? Are certain populations more at risk than others? For example, if we're starting with, say, cancer as the problem, a risk factor for cancer could potentially be smoking tobacco. So we want to identify what is the frequency of getting cancer in a population that smokes tobacco compared to those that do not smoke. And that is how we kind of get an idea of what might be driving the problem. The next step is evaluating the intervention that we want to implement. So what works? And we can do that by looking at evidence-based practices to see what's already out there, or we can be innovative and try to come up with our own interventions. After we design our intervention, we want to evaluate to see that it actually works. So if we implement, for example, a tobacco cessation program, still going with my cancer example, we want to see if it is a program that people in the community are going to embrace, and we're going to start seeing a decrease in the amount of people who are smoking, which hopefully translates into the number of lung cancer cases that were reported. And the last part is the implementation bit, which is always a continuous process. It's not just something that you check off the box. You have your intervention, you implement it, and then you want to evaluate, make changes to it, and then implement. So it's kind of like a cycle with your implementation. So that's how you go from the problem itself and then responding to the problem. So what is epidemiology in itself? I know I tried to give the simplistic definition earlier, but we're going to look at a technical definition. It's basically the study of it's basically a study of the distribution and the determinants of health-related states in a specified population. And it's important that we include a specified population, because it's not epidemiology if it's not targeted to a population. It's not epidemiology if I'm just looking at one or two people. It has to be a group. It has to be a population. So it could be an age group. It could be a certain racial group. It could be a certain geographical location, but it has to be a study of the distribution of determinants of health within a group of people in a location or a specified group of people. So what is the process of epidemiology in public health? We start off by discovering the agent, the host, and environmental factors which kind of interact through what we call it's kind of a triad. So you have it looking like a triangle. You have the agent, the host, and then the environmental factors, all of them interacting to interacting to cause a problem or interacting to manifest a problem. Now we want to determine, after we were able to discover what the agent is, we want to determine what are the importance of these agents or these environmental factors to cause an illness, disability, and death. And then we want to identify population groups who are at greatest risk, because we always want the biggest bang for our buck. So we want to make sure that we're targeting epidemiological interventions and public health interventions for that matter to populations who most need them. So those who are at greatest risk are those that we want to spend the little dollar that we have on to get the biggest impact. Now, after we do that, we want to evaluate the effectiveness of the program, which I have said earlier. You don't just implement and then check it off your list. Well, so we have a very good intervention, we have implemented it, and then that's the end of the day. But what you need to do, you have to constantly evaluate the effectiveness of whatever programs that you're implementing, and then making sure that they are serving the desired population and resulting in the right outcomes. So step one, this is my favorite part of epidemiology data collection and assessment. You cannot do epidemiology without data. And we have different forms of data. You might want to collect it personally, which is primary data, or you might want to use data that's already stored in repositories, like the Missouri Student Survey, like the BRFSS. Those are all secondary data because they're already collected and they're stored in a repository where you can go and take out some aspects of it and analyze based on whatever question you're looking to address. So first step to solving problems with epidemiology is data collection. If you cannot do data collection, then you use secondary data. But data collection is key to collect primary data. And you can do that through surveillance. And typically with surveillance data, it has to do with, it's more descriptive. It talks about the person, the place, and the time. So for example, if we have a problem of underage drinking in Greene County, we're gonna collect surveillance data on so who are the group at risk or who are the group engaging in the behavior. Well, we identify college students, so that is the person. Where is the place? Where do they typically go out, or where do we typically see lots of underage drinking? It might be at parties, it might be at frat houses, or it might be at social events. So that becomes a place. And then we want to determine the time. When do we typically see underage drinking occur? Does it occur? Is it seasonal? Does it occur in the summer? Does it occur all year round? Does it occur at night? That is what we mean by time. And those are the factors that goes into surveillance data collection for epidemiology. Then you want to do an assessment. What your assessment does is it helps you to come out with an inference. So you want to be able to determine, after my data collection, what I want to do is be able to look at the data and determine if we do have a problem for sure. Do we or do we not? So that is where you draw your inference, and your inference could be that it looks like we have a problem here. Kids out here drinking when they shouldn't. So then you go to step 3, which is formulating your hypothesis. So you want to formulate a hypothesis, and for example, you could say maybe college students under age 21 drink during the summers. That would be a hypothesis, and your alternative would be that they do not drink during the summer, and then you want to go a step further to analyze that and see if that is true or not. It gets complicated with the statistical analysis bit, which I would not go so much into. And then the last part is action. Action. You don't want to collect data, you don't want to do an assessment and formulate a hypothesis, test it, and not do anything with it. It's as good as nothing if you do not act. So what you want to do is you want to act on your hypothesis and come out with an intervention. So you come out with an intervention which would be targeted. Mind you, you started with surveillance, so you know the time. At this point, you know the time, you know the place, you know the person. You've already drawn your inference, so you know what your problem is. Now you've been able to test the hypothesis to determine your how and why. And so your intervention at this point is going to be tailored to the target population. So it's kind of like you start off, it's kind of like a funnel. You start off with a lot of stuff or a lot of information at the top, and then you zero down to the bottom and strike a specific populational target. If you do not remember anything from this presentation this morning, at least I want you to remember one of these terminologies. That's how you go out into the community and sound like a fancy epidemiologist to begin with. So first of them is the rate, which is the measure of the frequency with which an event occurs in the population over a specified time. So we hear birth rate, we hear death rate. Basically what it means is that we're not just looking at the counts. So it's sometimes misleading, for example, to say, we had 10 people die this year from lung cancer and then in Greene County, and then 20 people died from lung cancer in Taney County. So Greene County seems to be doing better than Greene County. Well, if you're looking at the counts, that's what it may look like. But if you look at the rates, it may tell a whole different story, because the rate puts into context the population of the area of the specified. It puts into context the population of the geographical location under consideration. So, for example, if we have the same population for Greene County and Taney counties, then a count of 20 cancer cases in Greene County would mean a lot more than 10 cases of cancer cases in Taney County, because we have the same population. But if we do not, then it's not right to just compare the numbers, because what you're doing is basically comparing mangoes with oranges. To compare oranges with oranges, you need to use the rate. Now, next term is proportion. What proportion basically is a part of the whole, so like a percentage. So we say, for example, 10% of males or female, or 10% of maybe underage drinkers are males, or underage students in Greene County who reported drinking are males or females. That is a proportion, and that is really what it is. Again, you want to use proportions with caution, because if I say that, for example, there was an increase of 100% in road accidents in Greene County, it just sounds alarming. But if I look at the data, it could mean that maybe we had just one death last year, now we have two. Yeah, that's a 100% increase. But it's really not that alarming if you see the raw figures and you see that it's just it's just going from 1 to 2. So again, you want to use proportions with caution. Next term that we're going to look at is incidence, and it's the occurrence of new cases. Keyword is new cases. Incidence, new cases, and that's the difference between incidence and prevalence. Incidence is just new cases. So we walk in the community, we want just the new cases. That's how we calculate incidence. So you get your number of new cases, divide that by the population over the time period that you're considering, or the time period that you're investigating, and that is your incidence. So for example, with COVID, if we wanted the incidence of COVID for the month of May, it would be how many new cases of COVID have we recorded in the month of May over how many people were exposed or were potentially at risk for COVID in Greene County during the month of May. Prevalence, on the other hand, deals with both new and pre or existing cases. So what it means is, again, with the COVID example, if we wanted to find out the prevalence of COVID in Greene County for the month of May, it would be how many people have COVID in the month of May. It doesn't matter if they had it in March or if they had it in April. Once they still have COVID, they're counted because they have COVID. So it's about new and old cases, just the total number of cases, new and old, and then we divide that by the population, or the population at risk. We like to say population at risk because you want to take out those who are not at risk. And for example, if somebody has COVID already, you cannot consider them to be at risk because they already have COVID. So yeah, that is the difference between incidence and then prevalence. And these words may have been on the airwaves for quite a bit now. So I just thought to add them to draw some distinctions so we know what is regarded as endemic, what an epidemic is, and what a pandemic, which is probably the most searched word on the internet now. So a disease condition or a health behavior is regarded as endemic if it is present in a population at all times. So it's at a threshold that is acceptable, then it is regarded as endemic. I grew up in the tropics in Africa, where malaria is regarded as an endemic condition because all year round, we expect to have a certain number of malaria cases. So it is endemic. You can't live in the tropics and not think of malaria. It's part of us. That's what endemic means. Now, if you take that a step further and you look at an epidemic is just disease occurrence above the normal or accepted threshold. So assuming it's okay to have 1,000 cases of malaria in my little country, Ghana, when we start seeing say 200 or 2,000 cases, that's alarming. That's beyond the accepted threshold. So then we're going to start looking at an epidemic situation. Now, when you have an epidemic situation translate onto the global scale or a worldwide, then we refer to it as a pandemic. That's why COVID is regarded as a pandemic, because COVID is not just a China problem, as we were made to believe. COVID is actually a global problem, and that's why we refer to it as a pandemic. You may have noticed that I skipped cluster because I just wanted to kind of go through endemic, epidemic, and pandemic. What a cluster means is just like the English meaning of the word. It's a grouping. So when you have cases of a condition, cases of a health behavior or disease, grouping in a certain age bracket or grouping in a certain location, then we have, when you have pockets of it, then we refer to it as a cluster. And that is important because sometimes you need that information to be able to identify where the first outbreak was recorded. When you're doing outbreak investigations, you're typically looking at clusters. You want to look at where you have clusters on your geomaps, and then going to investigate further to identify when the first case was recorded. So how do we calculate risk? I've already said, it's not enough to just look at the numbers, the counts. It's easier to just, go about counting and saying, we have this number of cases and this other county has this number of cases, so we're better off. But the counts doesn't tell the whole picture. So do not just stay on the counts. You wanna transform them into rates if possible. And this is the formula for calculating the rate, I should say. It takes the number of cases, which could be for an illness or condition. It takes the size of the population. And then the third and very important aspect is time. You can't calculate a rate without including time. If you do not include the time, it becomes a proportion. It's not a rate. So bear that in mind. So it's number of cases per the population at risk over a specified period of time. That is the rate. So we're going to look at epidemiology study types. There's basically two broad types of studies that we conduct in epidemiology. There's the experimental and there's the observational. Experimental, I want y'all to think of experimental as your clinical trials. That's really what experimental data is, experimental study is. With experimental studies, what happens is you have your investigator or researcher manipulating or controlling the subjects. So like with a clinical trial, they actually administer an agent or they actually administer a drug to one group and give a placebo to another group and try to compare if there's any benefit for or adverse events for the group that got the drug compared to those that didn't. So that's experimental because you have an actual administration of an agent, an actual exposure going on there. Now with observational, we do not manipulate the subjects. So we're basically, like it sounds, we're just observing, we're just looking. So we're looking at, say, Greene County. We come into Greene County and we're just looking to see if we have a problem. We have, a lung cancer problem in Greene County. What we might do is go to the lung cancer registry for Greene County, if we do have that, and we want to see if there has been a trend of cases over a period of time. Are we seeing cases rise over a specified period of time? Are we seeing cases decrease? Are we seeing a certain age group reporting more for the case under investigation? Are we seeing a certain race? Are we seeing a certain gender? That is kind of what goes on with observational on the descriptive arm. So then the descriptive arm, we're going to just describe it and say, for example, persons aged, say, 60 and older who are male and Caucasian are maybe 4 times at risk of lung cancer compared to those who are not in Greene County. That's really what it is with the descriptive part. We're just going to describe what the frequencies are. We're going to look at it for different age groups. We're going to look at it for different gender. We're going to look at it for places. Now with the analytic, it gets a lot more complicated because then you go into using more of the statistics. You go into doing complicated stuff like regression, chi-squares, t-test, and all of that to compare if, for example, the rate of lung cancer in age group Y is any different from the rate of lung cancer in age group X. So that is more of the analytic aspect. I touched on that, so I wouldn't dwell. This is basically everything I was saying, so I'm not going to dwell on that. On this slide, it's just a little activity. I'm just going to go across from A to C. If you think the answer is A, give me a thumbs up. If you think it's B, give me a thumbs up. If you think it's C, give me a thumbs up. So an epidemiologist is doing a study on the sleep patterns of college students, but does not provide any intervention. What type of study is this? Is it A, qualitative? Do I see any thumb go up? No, I don't. B, experimental? Do I see any thumb? No, I do not. C, observational? Thumbs go up? Yay. So we got it. It is observational. The key word is no intervention. So we're not providing any form of intervention. We're just observing. We're just observing for patterns. That's all. All right. Next question. A study of heart disease comparing group who eats healthy foods and exercises regularly with one who does not in an effort to test association. Is it A, descriptive? Is it B, analytic? I don't think I saw any thumb go up for either of them. Okay, I see one now. So we're saying number one is analytic. Is that it? Everybody saying analytic for number one? Okay, let's go on to question two. That might help you change your mind or not. So a study is to describe the eating habits of adolescents aged 13 to 18 years in community X. Is that descriptive? Is that analytic? Okay, at this point, I don't see anybody say it's descriptive or analytic. Now, so if you said number one, I mean, if you said in your hearts, because your thumb didn't go up, that number one was analytic, you'd be right.
That's what I said.
If you, okay, good job, Steve. If you said it was descriptive for number two, you would be right. Because number two is basically describing the eating habits. That's all we're doing. We're only describing it. We're not going into the nitty. We're not testing association. We're not comparing nothing to nothing. We're just saying if you take 13 to 18-year-olds in community X, they have a certain pattern of eating. That's all we're saying. We're just describing it. And then number one is where we actually go in and do stuff like chi-squares, because that's what we typically do to test association. It's doing analysis like a chi-square. So analytic, number one, descriptive, number two. All right. We're going to talk about a few data sources and data collection methods. So remember how I started off saying you can have primary and secondary data? Primary data is data that you actually collect. So if I'm doing a survey collecting data, or if I'm recruiting people for a clinical trial, that is primary data collection. I'm actually getting people to tell me stuff or give me their data. Secondary is if I am just going to a repository and looking at the variables and conducting my own analysis with that. So sources, we can get data from individuals. We typically do that through surveys and questionnaires. We can do that through the environment, which is more of environmental health. You can go out and take samples of, say, water samples. You can trap mosquitoes and pin them, test them for a virus. That is also a form of data collection. You can test for the air quality in different parts of a state or different parts of a county. That is also a form of data collection because you want to measure the level of pollution. We can get data from healthcare providers, and this we would get from like the health records. So the EHR or EMR records is a form of source of data. And then we have non-health related sources like the tobacco sales, for example, or the court records. If we want to measure to see if we're having a rise in misdemeanors, we want to go check out the court records to be able to measure that. So those are all sources of data that we can use as epidemiologists and inform whatever intervention or analysis that we want to carry out to address identified problems in our communities. So after data collection, you have to come out with what we call your hypothesis. Your hypothesis is basically, it's kind of an assumption that you're wanting to prove, that is really what your hypothesis is. So you could be wrong in your hypothesis based on how your analysis turns out. So it's not like you always have to prove that you're right. That's not how it works. So you assume that, for example, whenever the first epidemiologist, who goes by the name Dr. Jon Snow, and I don't mean the one from Game of Thrones. So whenever Dr. Jon Snow embarked on the first epidemiological study, it had to do with cholera outbreak in London. Yes, it used to be a filthy city back in the day. So what they saw at the time was just people having vomiting and diarrhea and dying without any cause. They couldn't explain what the problem was. So then Dr. Jon Snow started to investigate that. So at the time, there were all forms of hypotheses. People thought it was witchcraft. So that would be a hypothesis, an assumption that people got cholera because they were bewitched. Jon Snow's hypothesis was that his hypothesis was that people got cholera when they drank from a certain pump located in the central part of London. So that was his hypothesis. Now, to test that hypothesis, he basically had to have people drink from that pump and others who would drink from a different pump to see if they got cholera or not. Lo and behold, those that drank from the central London pump got cholera, and those who did not didn't get cholera. And that was the very first epidemiological study. Very crude in its form, but it did the trick. So first, you want to collect data, and then first, so with the Jon Snow example, his data collection led him to realize that cholera may have been associated with the pump in central London, and if you read the history, he basically went from house to house and did an investigation on where households got their water from and on whether they had recorded any cases of cholera in their households. So it was that data collection that led him to form that hypothesis that cholera might be associated with drinking from the pump in central London. So once you form that hypothesis, then you want to be able to analyze, you want to test it. It may be right or wrong, you want to test it. And then after you conduct your studies to test it, then you analyze, you test by analyzing, you come up with your statistical p-values and all of that. And if it turns out that it's significant, then you say, okay, so there is a significant association or not. So basically in epidemiology, in summary, we conduct studies in an attempt to discover associations between exposure and risk factors. So in the Jon Snow example, the exposure would be drinking from the pump in central London. Have you drunk from the pump or not? That would be the exposure. The risk, the risk factor becomes, it could be a lot of things. It could be that you probably were poor enough to go to a different pump. It could be that you weren't dieting properly, so had a compromised immune system. Those are all risk factors that could have contributed to people getting cholera beyond just being exposed to the water. But those are factors that you would have to investigate further to establish. But first you start with your exposure, and then you go to your outcome. So did people drink from the pump? Yes, they did. Outcome is cholera. Did they get cholera? Yes, they did. Okay, so then drinking from the pump could be the first risk factor. But then we want to investigate other risk factors. Are they drinking from the pump because it's the closest, or is it because they can't afford to go to other places to get water? Are they drinking from the pump because there are people who may have drunk from the pump and not got sick. So why did they get sick when they drank from the pump? Is it because they're immunocompromised and stuff like that? So that's how we do all these investigations. And I took out just about 2 or 3 study designs. There's a lot of them. But again, like I said, I try to make this presentation very, very simple as I possibly could. So first of them that I want us to look at is the cross-sectional study. A cross-section, think of it as just a scan. That's a cross-sectional study. You basically walk into a room or you walk into a county and then you're like, how many people got COVID today? And they tell you maybe 10 people got COVID today. That's a study right there. But is it a strong study? It's not. But it's good because it helps you gather exploratory data. You don't want to start pumping effort and money into research that yields nothing. So typically we start off with just cross-sectional studies to actually determine or decide if a problem is actually worth investigating or getting into or pumping all that money and researching. So the next one is the cohort. And when you hear cohort, I want you to think time. So when you hear cohort, I just want you to think time, cohort. So what a cohort study is basically a study of following people through time. That's really what it is. So that's what a cohort study is. We're just following people through time. So today, we may start off with maybe a cohort of 100 people. Maybe 20 of them have fever, 80 of them are okay. We're gonna follow them maybe for a month and check again what's going on with this cohort. Maybe we may have 50 people having fever now and 50 not having fever. So then we have different endpoints for a cohort study. We have the baseline, which is what we start off with, and then we can have different secondary endpoints as we go along, or we can just make it endpoint, end line. It's all up to how the research or the study is designed. If we have multiple endpoints, we can measure different outcomes. We could measure, for example, if people are losing weight. We can measure if, for example, people are getting fever. Like I said, we can measure if they're exercising more or less and stuff like that, and what impact all of those activities is having on the overall outcome. We might be interested in, for example, investigating heart disease. So we're going to look at how all of these factors in the long term at our end line impacted the occurrence of heart disease. Case control, which is going to be the third one we look at, and the last one, like I said, there's a lot of case designs, but I wanted us to just look at these 3. With case control, we basically match cases with controls. That's the name. That's how come we got the name case control. So we're matching cases with controls. And what we do typically is we use medical records to do this. So we would go into your EMR, EHR, identify a pool of cases for a condition or disease. So we go in and we identify that there's maybe 100 cases of COVID for the month of May from the EHR. Now, what we're going to do is now look at what the characteristics of these 100 people are. Are they, what is their race? What is their gender? What is the distribution like? What is the age, gender? What is the race? All of that. And then we're going to try to find 100 healthy people who match these characteristics. And we're going to use them to serve as our controls. And that's what we do with a case control. So you find your cases, and then you find a comparable group to serve as a control, and then you run your analysis to see if there's really any association between exposure and outcomes. Fun activity. Hopefully we'll have a lot more participation. So number one, subjects with diabetes are compared with subjects without diabetes. A is cross-sectional, B cohort, C case control. A, thumbs up, B, thumbs up, C, thumbs up. Okay. I didn't get, did I see any? I don't think I did. Maybe I missed it. Number two, a study of women aged 50 to 60 years in a community located close to a nuclear power facility. A, cross-sectional, B, cohort, C, case control. So A, thumbs up, B, cohort. Okay, I see some thumbs up for cohort for B. C, case control. Okay. The last one, subjects who have received nutritional counseling and who have exercised twice a week are compared with subjects who have not. A, cross-sectional. B, cohort. C, case control. Okay. So I see case control for number three. Now let's look at it together. So number one, subjects with diabetes are compared with subjects without diabetes. There's a comparison. I told you, you have to have your cases and you have to have your non-cases. So that would be a case control. Number two, a study of women aged 50 to 60 years in a community located close to a nuclear facility. Does it tell us what's really going on with that population besides that they're 50 to 60 years and where they live? No, it doesn't tell us anything more beyond that. It only tells us we're looking at 50 to 60-year-old women living close to a nuclear facility, which clearly tells me that would be a cross-sectional study. The third one, subjects who have received nutritional counseling and who have exercised twice a week are compared with subjects who have not. What did I say about a cohort? I know there's a comparison, but I said think of a time element when you hear a cohort. So they exercise for 2 weeks, which is why it's a cohort. So we must have followed them for 2 weeks to know they exercise for 2 weeks. That's why it's a cohort. All right. If you got all three, clap for yourself. If you got any of them wrong, hopefully you have learned, and we'll be able to score all three on the next test. I'm kidding. We're not going to have any more of those. So the last part is just investigating an outbreak. And there are 10 steps which go into investigating outbreaks. We're basically going to establish the existence of the outbreak. We can't just go about fictitious outbreaks. We need to actually know it's an outbreak for real. So how we do that is, again, you guessed right, data collection. So we have to collect data. Like I said, you can't do any epi work without data. We have to collect the data to be able to establish the existence of an outbreak. And then the next step would be to prepare for field work. Then we verify what we think our diagnosis is or our hypothesis. We verify that to ensure that we're not missing the point. Then we define and identify cases. We got to have a definition for our cases because we can't just go and assume that if everybody comes looking a certain way, they're sick. We should have a definition that you have to meet to be classified as a case. You know, with COVID, for example, you have to have a fever, you have to be coughing, you have to be exhibiting a certain amount of symptoms for you to be regarded as a potential case. Of course, we have to confirm with a test to conclusively say you were a case, but at least you have to have those signs and symptoms for us to even start thinking of considering you as a case. And that's the same with Every case investigation or every outbreak investigation, you got to have a very specific guideline or definition on who qualifies to be a case and who doesn't. And then we want to do a bit of descriptive epidemiology. Descriptive epidemiology is just what we call the PPT. You're talking about person, place, time. If it makes you remember, PPT also stands for PowerPoint. So PPT, person, place, time, is what we mean when we talk descriptive epidemiology. Person, we're talking about characteristics of a person. So think of you as a person, your race, your gender, your socioeconomic status, all the demographic data that we typically collect. That's the person. Place, where do you live? Are you in the US? Are you in the UK? Are you in Africa? Are you regarded third world, middle world, high income countries? That is where. Are you in a tropical location? Are you in a temperate location? That is the where, or the place. And then the time element is is it seasonal? You know, is it something that happens yearly? Is it something that happens in the summer only, in the winter only? Is it something that happens, or are we studying this event over a 1 year period, over a month period, over a 2-week period? That is the time element. Now we develop our hypothesis. So we formulate our hypothesis, then we evaluate those hypotheses, we refine them as we go along. If we realize that we may have made some erroneous assumptions, we can refine them. And then we go on to test that hypothesis and implement prevention measures. What is the use of having a research finding if you don't share it? So that's the last part. You got to communicate your findings. Okay, you do all of these hard work so you can share your findings, so those findings can be used to implement policies. They can be used to implement either future interventions or future investigations. So in summary, we have looked at what epidemiology is. We looked at a definition for it. We looked at some basic terminologies and concepts. We looked at types of data and the data sources. We talked about the data collection methods and how to interpret data. We looked at a public health problem in terms of place, person, and time, which is descriptive epidemiology. And we have identified key components of descriptive epidemiology in outbreak investigations. Hopefully I have made a lot more sense than nonsense with my presentation. At this point, I would open up for questions from the audience. And like we say at CPO, every question is welcome. There's nothing like a good or bad question.
Questions from anyone in the audience?
Are y'all excited about going out and showing off your new terminologies in epidemiology?
Actually, I found it very helpful, and I didn't do so well on the second quiz that you did, but then after you explained it, it just helped to illustrate it even more. So I want to let everybody know that there was a lot of information presented within this presentation, and we do, this has been recorded and we post them on the our YouTube channel. It's at CP Ozarks. So there's a whole playlist of previous prevention perks, and this will be one of those that that I'll upload later this morning after I get back into the office. So if you want to share it with other people on your coalition, or if you want to review it for yourself, that's where you will be able to find it. Clement, do you want to post your email address in the chat? And if people have a question or they want to connect with you about maybe some research that they're doing or an evaluation component of something they're doing in their community, that maybe they could call on you for some assistance.
Sure, type it in right now.
Jill said that in the chat that she's glad that she finally understands what they mean when they talk about incidents of COVID. And that was the one thing when you said new occurrence, it was like, oh, I never thought of it like that. I mean, I could use the term incidents, but I would think of it in a broader sense. But from this perspective, it's really just looking at what are the new cases or the new occurrences. So that was my takeaway also, Jill. We're on the same page.
All right, so I'm going to stop sharing my screen.
All right. Well, I appreciate your time, Clement. And like I said, it will be hosted on the YouTube channel at CP Ozarks. If you want to review this, share it with your coalition members, or maybe just to refresh your memory yourself. So appreciate your time with us today, and thanks everyone for being here. There will be a announcement sent out in the next week or so about the upcoming prevention perk, and then we'll have a new schedule that will follow with that. So hopefully we'll see you on a future perk segment. Thanks, everyone.